This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast.
All right, take two of us trying to record. Welcome back, everybody, to the Alert Medic 1 podcast. Really excited to have two guests on, Kenny Barajas and Lindsay Goff. Kenny, I'll let you introduce yourself first, and then we'll let Lindsay introduce herself.
Yeah, thanks so much for having me. This is Kenny Barajas. I am the Chief of the Office of Care and Integration for the State of Maryland MIMS agency. I'm happy to be here and excited to talk about stroke.
Kenny, what does that mean? Can you tell the listeners, like you just said, the Office of Care and Integration, what does that mean?
Yes, what it means is that we are in a service line that looks at systems of care when it comes to stroke care, starting from the initial phone call that is made to 911. We are educators, mentors. We provide guidelines to EMS personnel. We coach them on what to do on scene. We coach them on what to do and what to assess for during transport. And then we designate the facilities that stroke patients can go to. So we're the state designee agency service line for stroke. And we actually guide EMS on where to go when they do an assessment for a stroke patient.
Great. And among, apart from stroke, today's conversation topic is going to be stroke for EMS, but your office also covers the cardiac program, trauma, and the perinatal programs, correct?
Yes, we do. Like I said, trauma. We also do a specialty centers like burns. We do eye trauma. We do hand trauma. We get specialized, but all the cardiac service line, yes, perinatal as well. And we also manage the freestanding ERs in the state.
Perfect. Lindsay?
Hi, everyone. My name is Lindsay Goff. I am the stroke program coordinator for University of Maryland Upper Chesapeake Health, also our Aberdeen campus. In addition to being an ER nurse in trade, I also have been a paramedic for 10 years in Maryland. So happy to be here. So thank you.
Yeah, absolutely. And so, jumping right into it, stroke is one of those things where EMS can have a major impact for patients. And certainly one of the most debilitating injuries can turn into a lower impact injury if we, take care of a few things and get the patient to the hospital immediately. So I'll give it to Lindsay first. If you were to define, a stroke, and I know this might sound super basic for our listeners, but I think we should start at the foundation. How do you define a stroke? What are the hallmark signs? And yeah, go ahead.
So to define stroke, before we get into the subtypes, when you talk about a stroke, it's a disruption, in blood flow to your brain. So that could be either from an ischemic stroke, so a clot obstructing that blood flow, or it could be from a vessel that is ruptured and that blood that ruptured from that vessel is sitting on that brain tissue. So both of those things, cause the brain to not be perfused and then manifests clinically in neurologic symptoms. So when we look at what are the signs and symptoms of stroke, we use a BFAST algorithm. We use it in Maryland, we use it in the United States, and we use it across the country also. What that acronym stands for, wow, I can't talk today. So the B is for balance. So any acute onset of any balance, worst headache of your life, feeling like your coordination is off. The E is for eyes. So any loss of vision, blurred vision, double vision in one or both eyes with acute onset. F is for face. So then we look at one side of your face drooping. If it's numb, you can't drink out of a straw and you can't control your secretions. And then we look at the arms. So if one side of your body is weak or numb and you can't use it, we also look at the S is for speech. So any difficulty getting your words out or understanding what other people are saying. Then the T stands for time, because it's very important. Like you said, Moose, it's a time-sensitive disease. So onset of symptoms to 4.5 hours to administer the clot-busting medicine. So yeah.
Kenny, did you have anything to add?
No, I just want to reiterate what you said for your listeners to truly understand how bad this thing is, right? So I want to give you some idea of how bad a stroke really is. Approximately 1/3 of patients that are diagnosed with a stroke are no longer alive within 1 year after the incident, right? 31% need help taking care of themselves. If they survive for the rest of their lives, they need help taking care of themselves. 33 develop depression. 20% need some type of assistance for walking. 16% need placement in assisted living. So they never get to go home from that incident. This is how bad it is and how important it is for us to understand how to tackle this disease.
And just to add to that, I mean, what I teach to not just my, paramedics and my EMTs and my EMS providers, but I also teach this to physicians, to ER nurses, to anybody that will listen, is that stroke is the number one cause of long-term disability. And as Kenny said, the second that these patients experience this sudden, tragic event, not just their lives, but their, family members' lives, their caregivers' lives are forever changed from that moment. And it cannot be reversed. So that's what sets this disease process apart from any other one that I think we experience as EMS providers. And they aren't, hemodynamically unstable, and they, aren't the gunshot, wound, there aren't the cardiac arrest, it's not, the needle decompression, but you can truly save these patients' lives from that permanent disability.
So, Kenny, you talked a little bit about the the morbidity and mortality. Can you talk a little bit further about what kind of influences on mortality? What causes folks to be more, have a better or negative good outcome or negative outcome?
Yeah, there's many things that we call comorbidities, or things that make it worse. And someone that has a comorbidity like hypertension that's uncontrolled, someone that has atrial fibrillation, someone has diabetes, someone that has high cholesterol, someone who smokes. These are the things that make it worse when someone does have a stroke. There's many things that we can control and that we can control. And these are risk factors, and things like age. It is what it is, right? You're at the age, the older you are, the more difficult time you have, So there's things like race. Different races have a higher incidence of stroke, and it can cause them to have a larger disability as well. So, but there's the other things that I mentioned, like hypertension, high cholesterol, atrial fibrillation. These are the things that we can control. And a lot of times we don't do a really good job at controlling these things. So that's what can make things worse.
Lindsay, did you have something?
I mean, just to, add on to what Kenny said, and what we, think about as nurses, we preach primary prevention. We also preach modifying risk factors, and something we don't really think about every day, even for ourselves. But when we look at the two different types of things, risk factors that will increase your chances of having a stroke, as Kenny said, you have, the modifiable. These are things that we can change, our diet, our exercise, correcting our blood sugar, our cholesterol, our blood pressure. The things that we cannot change, so the non-modifiable, these are things that we're born with, age, race, gender, ethnicity. But I mean, the things that we can change truly will make a difference.
It's interesting to me when we talk about, the risk factors, the commonalities between stroke, heart disease, and the other, big killers like cancer, Alzheimer's. They all have similar comorbidities in hypertension, diabetes, high cholesterol, smoking, and all of those have a commonalities in disease process, right? Number one, we talk about endothelial damage, right? Some sort of endothelial damage. And what do I mean by that? I mean vessel wall, disruption and loss of integrity, which then in turn causes an inflammatory response in all of those diseases, right? I don't know. The more I get into EMS, the more I think the role of preventative medicine plays, right? We all know how tragic it is when we show up to a cardiac arrest and it's like a 50-some-year-old male who, was mowing his lawn, had chest pain, collapsed, went to cardiac arrest, and then, depending on multiple factors, we may not have a positive outcome. I can't help but think now that, we've all had patients like this, that disease process didn't start when the patient went down. That disease process started 30 years ago when he began having hypertension, and the role of what, I don't know, as I continue to think what the role of EMS is as we change, I can't help but think that there's a potential for EMS to play that preventative medicine, role as we move forward and we transition into the next iteration of what EMS will be for our citizens. But that's a conversation for another day. I just can't help but think about that. Lindsay, you talked about two basic, two types of stroke. Do you mind expanding on that?
Sure. I will start with the first one. The first one is the most common and the most prevalent in neurology and across the nation. It's called the ischemic stroke. So these are about 88% of our strokes. And why do we like these in neurology? We like this type of stroke because as of 2014, we have two separate treatments that we did not have to offer these patients in the past. And so, we like this because we can treat this type of stroke and try to eliminate the deficits as much as we can. And where do these types of strokes come from? I mean, when we look at the AHA data, 94% of that 88% come from AFib and irregular heartbeat. So these patients, are in and out of AFib and have their heart fluttering and they are asymptomatic, but that fluttering does predispose them for throwing a clot and it going to their brain. So, we have to preach primary prevention and seeing a primary care doctor. We, want these patients to get routine physicals so that we can look for this. Something that I teach to EMS providers that I used to do as a paramedic when, you put somebody on a monitor, even a 3-lead, and you see AFib, you don't see P waves, you see, an irregular, rate. What do we ask? Do you have a history of AFib? And if they don't, then that's something that you need to include in your, handoff report to the ER. Just something that I did in practice, and I try to remind providers for that reason. So we'll go to the second type of stroke. This is called the bleeding stroke, so the hemorrhagic stroke. It's about 12% of our strokes nationally, thankfully, because these types of strokes tend to have a more poor prognosis. Depends on how much blood, how much, how high your blood pressure is, where the bleeding is coming from. Imagine trying to figure out where, a hole was in a boat in dark water. That's essentially what it's like trying to find a bleeder when you have an intracranial bleed. So, we have those two types, but then we also have a mini stroke. And I clarify this with everyone. And, Kenny, I'm sorry, you're probably going to get tired of me saying this in all my presentations, but it's not the third type, but a TIA, a mini stroke. So what is that? A lot of times when, you go in these houses and you ask patients, have you ever had heart attack, strokes? They say, no, I just had a mini stroke. If you ask them, did it leave you with any deficits after? And if they say, yes, my speech, or yes, one side of my body is weak, they didn't have a mini stroke. They actually had a stroke. But why are we also concerned with these in not just neurology, not just in the hospital, but we also should be, looking at this as paramedics? A TIA is a warning sign. You have a clot sitting somewhere, and when it was stuck in between two vessels, it had an acute onset of neurologic deficit. But when that vessel went down the left side or down the right side of, whichever vessel on the sides of the bifurcation, those symptoms resolve. And how many calls did we go on as medics? I can, look at all three of you and say hundreds of these patients that, why do I need to go to the hospital because my symptoms are gone? Again, I am trying to educate my EMS providers as the EMS subcommittee chair for stroke for the state, is that I want you to teach patients that a TIA or a mini stroke is truly a warning sign. And if they aren't, looked at and we don't modify risk factors, those TIAs and episodes will get more frequent and more severe in nature and will not resolve eventually. So that's something that, I want to take to my EMS providers.
And to kind of hit on that last point, Lindsay, for the providers out there, it's important that we pay attention to our patient's status during transport. Does it resolve or does it not resolve during our transport? And there's actually a very specific drop-down menu in eMeds for this, and there's a reason. So we can track this properly so that this goes into the patient's chart. And even if we forget to do this in handoff, the doc forgets to tell the neurologist, whatever it is, at least it's somewhere in the chart that they can look back and say, hey, when this patient called for a stroke, it resolved in EMS presence. So we're thinking more TIA, more quote unquote mini stroke. And it's just important that we make sure we document this and we hand it off correctly. And not just be like, yeah, well, they called for a stroke and they're fine right now, or whatever it is. And to, kind of hit again on the importance of this, we kind of stress with our patients, our cardiac patients that have chest pain that, hey, could be angina, could be something coming down the road. Okay. There's only so much that we can do to take a look at this. And especially with the TIA, they can end up doing that CTA and find where that small transient clot is. I'd say probably a lot easier than finding the small transient clot that causes angina, because that's a much more invasive procedure to figure that one out. But they can catch these things early. They can head them off. And in fact, what Moose was saying, preventive medicine. We're getting them to the hospital earlier. We're getting them treated earlier, and possibly avoiding this whole downward spiral that can come from a major event that is being kind of foreshadowed. So
I just have two things to add to that. Sorry, Kenny, I don't want to dominate the conversation. But when you talk about resolvement of symptoms, yes, it's very important data to track. But something that I didn't know as a paramedic, and I know as an ER nurse, and I know very, very well, yes, I know it, Kenny, don't worry, as a stroke coordinator, is that if symptoms are resolving in these patients, that actually is an exclusion criteria for administering IV thrombolytics, because risk outweighs the benefit. So if patients, why do we give this drug? It's to, hopefully eliminate debilitating deficit. But if the symptoms are resolving and we still give that medication and the patient does have a bleed adversely, then, we did more harm than good. So that also is important to add, to my EMS providers listening, that it's very important to, either via EMRC in your consult or at that, face-to-face handoff, is adding if the symptoms are staying the same, getting worse, or getting better, because that could also, dictate a treatment modality for them.
And for our listeners from across the nation, or if you're listening from another country, what Lindsay meant by EMRC is the Emergency Medical Resource Center. It's just, think of it as our, in Maryland, the way EMS clinicians communicate with their hospital. It would be no different than how you would communicate with maybe medical direction, or how you would notify your hospitals. Hey, and either of you can take this question. I wanted to dive a little bit deeper into Josh got me thinking when you made the cardiac analogy of the disease process specifically for ischemic stroke, and the rates of embolic versus thrombotic strokes, and if they present differently at all. So for the folks that may not know, embolism is something where a clot or something else develops somewhere else in the body and then travels to the head, whereas a thrombosis, the way I think about it, is more of a native blockage of stenosis or hardening and stuff like that. So either of you can take that. I didn't know what the rates were and what the prognosis was, so on and so forth. And if were any particular vessels where stenosis or something occurs that maybe a neurologist looks for.
Kenny, I'll let you take this one.
Those the thrombotic and embolic strokes, right? They're classified into the ischemic stroke side versus the hemorrhagic, and we really can't tell, where it originated from, but we can tell where it ends and where we see it at. right? Now, if we can guess by what kind of problems the patient has, what kind of medications they're taking, how old they are, we can kind of guess, but it really falls into that bucket of ischemic stroke. And I don't think we've studied exactly what the percentages are because we really can't capture that. It ends where it ends, and that's when the symptoms start, and then they travel to the hospital. The thing about hemorrhagic strokes, which is something that your listeners, I'm sure they know, and whenever you have bleeding within the skull, that term is intracranial hemorrhage, right? All intracranial hemorrhages may not be strokes. There's a difference. In stroke, we look at two areas of the brain, right? One inside the brain tissue. If blood is inside the brain tissue, that's an intracerebral hemorrhage. So you're bleeding within the brain. Now, the other stroke has to do within certain layers of the brain. So if you have your brain, the first layer sitting on the brain, like the red of an apple, is called the pia mater. The next layer is called the arachnoid matter. And then you have the dura mater. In stroke, the layer under the space underneath the arachnoid layer, which is a subarachnoid space, is where we consider a vascular disease or stroke. So if you bleed because of a weakened artery, we call it an aneurysmal subarachnoid hemorrhage, which is a stroke. Anything above that is not considered a stroke. It is considered an intracerebral, intracranial hemorrhage, but not intracerebral. So we have to distinguish the difference because there is.
Yeah, no, certainly, I appreciate that. I don't want to belabor the point, but I have one more question based off my previous question. So, we look at things like calcium scores and stuff like that for the risk of cardiac disease. Is there anything equivalent like that for stroke risk?
No.
No, that sucks.
There's markers that are being studied right now that can send a signal that we can capture via blood, but it's not highly reliable at this time.
So we got some business opportunities to take advantage of, Kenny.
Absolutely.
Count
right.
me in, guys.
Yeah.
So
all right. Oh, go ahead.
So, Kenny, it's interesting you bring up the intercranial, intracerebral, all the different levels where we're looking, and it's interesting because I ran a call the other day before I went on vacation, and the patient in the follow-up, he initially had a subarachnoid hemorrhage that resulted in a fall that resulted in a subdural hematoma.
Absolutely.
He eventually did pass. He was a much older gentleman, but yeah, it's interesting how you can have both, one causing one over the other.
Absolutely.
And how this guy presented, definitely presented like a fall trauma, not a stroke trauma.
Yeah.
And so like end up going to a facility that does both, but in the end, it's just an interesting coincidence you bring that up. And I was like, oh wait, I have a patient that was just the combination of all that. So
Absolutely.
How many do we have of those, though, Josh, that we didn't think about? Could they have had some syncopal? I mean, yes, we asked about syncopal episodes, but were we truly thinking, did this patient have a subarachnoid, hemorrhage that caused this fall, that caused this? No, we didn't.
Yeah. This just happened to have a follow-up attached to it, luckily. So,
So is there a big difference in how patients are treated for bleeding in the brain based on whether or not it's a hemorrhagic stroke or more of a trauma?
Yes, there is. Yes, there is. So one example of many is if you have an aneurysmal subarachnoid hemorrhage, that's usually a vessel that's weakened and there's a burst on the side of it. So there's many things we can do. We can clip it. So do a surgical procedure, open the skull and clip that to stop the bleed. Or we can put coils, some metallic coils that go in and fill the space and prevent blood from leaking out, and eventually the body would help recover itself. So there is different treatments depending on where it's at and why it occurred.
So,
Thank you.
Sorry, Ken, did you have a follow-up? Okay. So let's, I think we've talked about at length about the different types. Let's talk about the EMS management next. And Lindsay, maybe you can take this. What's the, when we arrive on scene, and again, I know this might be some basics for some folks, but I think it's important to review the basics. What are we looking for? What tools are we using to assess for strokes, and what are some critical pearls that we need to get done before we get moving?
Oh man, this could be an entire podcast of a conversation, Moose. But what we use in Maryland, Dr. Chismar and Kenny, I verified with both of them what the order is for assessing these patients. So obviously, scene safe, BSI, I'm not going to go into step by step, don't worry, guys. But we're going to make sure their airway is secure. Just because they're having a stroke doesn't mean that they won't need intubation. So obviously, you're going to look at them, you're going to check ABCs, but after that, we start with the FAST exam. So face, arms, speech, and time. So if they're positive for that, so that's looking for any obvious strokes. Then we add, the B and the E to make B fast. So we use that next to look for posterior circulation strokes. So it adds that, dizziness, the balance, the visual disturbances to the mix. And then after that, we use the Los Angeles Motor Scale. So you guys know this, but what does it look for? And I think clarifying this protocol for EMS was very, very important because I think, we're a couple years into it, but there's still EMS providers that don't understand why. And the, LAMS looks for large vessel occlusions. It's a, type of ischemic stroke that are in large vessels in your brain that we can actually do clot retrieval on. The cool thing with that is we have onset of symptoms to 24 hours to pull these clots out of people's brains. It varies by facility to facility, state to state, but that's a long time frame. So, we look at, and EMS sees this. You guys see how busy hospitals are. You see how busy ERs are. But there are days, many days, that there are no neurocritical care beds in the entire state of Maryland or any surrounding, states. So what does that mean for these patients? If, you recognize that the patient had a LAMS of 4 and decided to take them directly to a comprehensive or thrombectomy capable stroke center that's within 30 minutes of a transport time, you could save that person's life. For multiple reasons, because 1, they're going to get a thrombectomy, but 2, they're going to get a thrombectomy in a timely fashion. Wow, I can't talk today. But so if you brought them to a primary stroke center, but they needed a comprehensive or thrombectomy capable, but there weren't any beds available, the patient can't go to a procedure. They should, and these hospitals, should make ghost beds for these patients, but that's not always feasible all of the time. So it's very important for EMS providers. You're going to do, the Cincinnati, you're going to do the FAST, you're going to do BFAST, you're going to do LAMS. But I also want you guys to think about what these patients need in the long term. And I think, EMS providers, we drop them off and that's really it. But thinking down the road, if this patient is a candidate to have that clot pulled out of their brain and they're on hour 20, we want to get them directly where they need to go. But when we also, for EMS providers, and I can speak for this to myself, is when you're on scene, there's a lot going on. I get it. You're busy. There's a lot of people talking to you, but try to find that patient's last known well time. Don't guess it. Please verify it. If you can't get a pinned down last known well time, at least, again, that's why it's very important to get the contact information so that, people like myself as stroke coordinators or ER doctors, that last known well time is going to dictate their treatment. So, if you just make up, a last known well time and it's either too soon or too late outside of that window, there's adverse events that could happen to this patient, or they could not receive treatment when they could have. So that's, something to remember. Please, guys, please get a last known well, investigate it.
So there are just a couple things I want to throw out there, both to Lindsay and Kenny, before I have to go for the evening here. One, stroke mimics, the importance of checking a blood glucose and getting a history of possible seizure activity preceding the stroke. 2, there's always a debate. I hear people argue this all the time. Is a stroke called ALS or BLS? And then 3, do we need to get a 12 lead on a stroke patient? Is that appropriate, or is that a time waster? So I'll leave
Ken
that
just
to
dropping all kinds of bombs.
Yeah, I wanted to drop a couple bombs before I had to roll out here, so
We're gonna let
I'll
Kenny
mute
answer
myself.
that one, Ken.
Yeah, so I want to back up a second because I think your listeners need to understand the importance of what Lindsay said. So I'm going to repeat what she said, and then I'm going to start answering some of your questions there, Ken. So one is the face, arm, and speech. It is important to understand that 80% of strokes will have one of those symptoms. You need to understand facial droop, arm weakness, and speech. It's really important that we master that. If so, 80% of them have at least one of those things, and just one of them gives you a 72% chance that you're having a stroke. So it's pretty good. All three combined, if you have it, it jumps up to 85%. So that's really important. And then the B and the E, she talked about the balance in the eyes, gives you that other 18 to 20%. So I'm glad you talked about glucose. Glucose is so important. I don't know if you know this or not, but 2/3 of the normal glucose consumption, if you eat a regular diet, as we all should, 2/3 of that glucose consumption is for the brain. So it's really important that you check that glucose. So great job bringing that up, right? So now on the EMS side, you talked about a EKG or putting them on a 12 lead. What I would advise is you look at your local protocols. How much that's going to change the treatment? We're not quite certain. It's probably not a lot, but it's a good extra finding or assessment that you can give the hospitals. For example, if you do pick up on that irregular beat as you're checking someone's pulse manually and you put them on a monitor, then if you see that AFib, you can say, this is probably where it came from. So it's just an extra tool. Look at your protocols to see if that's what they ask. Any assessment, any other finding that you can give the hospital becomes important. And Ken, remind me, there was one more thing: glucose, the 12 lead, and
ALS versus BLS. Is it more important to get the patient to the hospital or to get the ALS assessment in there somehow on the way to the hospital, or is it appropriate if you have somebody with no airway management issues to put them on the cot and beat feet to the certified stroke center?
Yeah. So I'm gonna punt it back and saying check your local jurisdictions, check your rules. But something that I do want you to know, that when someone is having a stroke, right, you lose 1.9 million brain cells per minute. You lose 13.8 million synapses. You lose 7 miles of axonal fibers when you're having a stroke. And every hour that you wait, your brain dies like a 3.6 years of the normal aging process. So I love the beat feet, get them to the hospital, but check your local jurisdictions and see what they require. I'm telling you, time is brain. The sooner we get to the treatment, the sooner we get the call, the sooner we start treating, the faster it is. So I'll punt that back to you EMS folks and let you know that I'd rather get someone else to do another assessment and find the same thing.
So what I'll say to the EMS personnel out there is this is like really like system and resource dependent. Like, and even then, when it's a heavily ALS resource department, that rendezvous time, that assessment time on scene, those minutes, this is where minutes equal like positive outcomes, negative outcomes type thing. I'd say it's probably, I don't want to maybe speak out of turn here, but probably more significant in a stroke than it is in a STEMI. That, that time factor, time is muscle, time is brain. I think it's more important in stroke. So the time is the big thing here. I know a lot of people like to say when it's the ALS side of it, you get the 18 gauge lock of love, and off you go to the hospital. I mean, in a ischemic stroke, there's not a whole lot outside of that requires ALS intervention. There are jurisdictions in Maryland and jurisdictions around the nation that there are EMTs that do IVs. And the prevalence of a ischemic stroke turning into a hemorrhagic stroke, leading to advanced airway management, is not high. It's not common. Typically, if they are a hemorrhagic stroke, you may see them progress from mild symptoms to extremely acute symptoms or high acuity stuff that you're going to have to manage on the way to the hospital. But your ischemics, I'm going to say most of them do not go that route, and I will say make the call on your own and look at the resources of your department. Resources in Moose's part-time job, they could be waiting a long time for ALS to show up.
Yes.
My department, a couple minutes, but still, like that whole time of getting the unit dispatched, figuring out where you're going to meet them, you can close that gap between you and the hospital.
And I think a lot of that, Josh, putting an ALS provider in front of that patient, and I mean, Kenny, correct me if I'm wrong, I think some of that, isn't just critical management. A paramedic is not going to drastically change the treatment physically, but maybe that transport decision. I think that speaks a lot to it too. I mean, there are departments that do train their EMS providers. I mean, I know DC gives their paramedics and their EMTs the same amazing stroke training, but not every department gets that. And I mean, yes, I've been on BLS units, with a partner that's either, better than me or, it's their first day on an ambulance. That's the beauty of EMS. But you also, getting on that unit, you have to be comfortable with making those transport decisions, not just for stroke patients, for anything else. But yes, I mean, time truly is brain, because we can transplant your lungs, we can transplant your kidneys. I can even transplant, Moose's face onto my face if I truly wanted to, or vice versa. Moose, you can take the hair, but we cannot transplant your brain. So that's, when we say time is brain, that's truly the reason why.
I think what I'm really hearing here is that this is a training and education issue, and that we need to make sure our EMTs and paramedics are taught to the highest standard when it comes to this stroke stuff, because it is so critical. It is so time critical. It is so life quality changing critical that we need to make sure that the new EMT has the same level of awareness of the issues as the veteran paramedic. And that's what it really comes down to. We need to make sure that we're empowering our new EMT with the knowledge that he or she is able to say, okay, this looks like we need to do a LAMS assessment, and now we need to go to a thrombectomy capable hospital because this LAMS score is high. I agree, with my experience, there's not been very many stroke patients, with the exception of some hemorrhagic strokes, where I needed to do anything ALS or anything wild like that. But what I have seen are people who maybe are missing some of that foundational knowledge, who look at a patient and say, this doesn't seem like that big of a deal. Why are we making this a priority one? Well, it's a stroke in the window, and we need to go to the right hospital at the right time, and that time is now.
Correct.
Agreed, Ken. The one of the arguments that is made often is that the ALS provider can give a better assessment and handoff at the hospital with PHI, so on and so forth, all the bits and pieces your handoff. A stroke, plain and simple, should be able to be handed off by an EMT or a paramedic at the same rate, because it's the same information that's being gathered. That topic of, do we need to do a 12 lead with a stroke? Personally, I favor on the side of no. Is it going to be clinically significant? No. There should be other things that are pointing towards doing a 12 lead with altered mental status, which you can catch a TAA with that. But that's not this topic. Everything else outside of the IV, which, like I said, in some areas is a BLS skill.
That's it.
You can do the same exact assessment Every EMT can do the same exact assessment I'm going to do, that Moose is going to do, that Ken's going to do, that Lindsay's going to do, and Kenny. Like, we're all doing the same thing. Is be fast. And then figure out which hospital to go to based off of that LAMP score. That's it.
Empower
then-
EMTs so that we can take the burden off of our ALS providers so that we can retain them in our state. And then we can, then we can mandate that you guys have had the same training as paramedics. So, stroke is a BLS skill unless you see X, Y, and Z. That'd be a good future to move towards.
Yeah, I love the conversation, and I certainly agree with you guys. Certainly transport should not be delayed for a 12 lead rate. And I know this is a very controversial topic, but I have to agree with you guys. I forget who said it, but there was this analogy made with like STEMIs. The thing is, the skill of assessing and interpreting the results of an assessment or an assessment tool for STEMI is an ALS skill. Thus, and a lot of the disease ramifications require ALS skills to fix, right? If you have someone that's having a STEMI and they start throwing, runs of VTAC that turn into VTAC, a paramedic needs to intervene there. There isn't really that sort of thing for stroke, right?
Right.
There is no special assessment tool you're going to get. The assessment tool is available to BLS providers. That absolutely, I agree that it has to be an education issue, and BLS providers have to be empowered to not only recognize stroke, but then transport to the appropriate destination. I think what we're all talking about, jives, right? Where things get a little hairy, and this is something, Josh and Ken know I experienced very recently, is the fast side of things. People are like, oh yeah, this is a stroke. But the balance and the eye issues are where the paramedic or the EMT will show up and say, hey, this is a priority 1 stroke alert. I've done it, blah, 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 and we'll expect an audience when they show up to the hospital, and the hospital may not treat them the same way. So what are some recommendations you guys have that, we can assess our hospital partner, or not assess, or, discuss, train, plan with our hospital partners to be able to treat the sudden loss of balance or the sudden loss or change in vision to be the same as the other symptoms.
Can I throw a follow-up question in there right before I go? And you don't have to answer it while I'm here. But just to follow up on what Moose said, I have heard some people say that they treat any new neurodeficit as a potential CVA. And I just wondered if you guys would agree with that thought process as well. And on that note, I'm going to have to take off. So thank you all for your time.
And to kind of add on top of this again, so the hospitals kind of disregard our imbalance and eye issues sometimes. But what about that provider, both BLS or ALS, that says it's vertigo, dizziness, it's vertigo? Because I know that was a super common question when the protocol was changed. And a super common thing to be saying, like, well, dizziness. Dizziness could be anything, But why is dizziness, and maybe how do we, is there a way to delineate this dizziness for a posterior cerebellar compared to vertigo or anything else? Or do we just lump it all together, and then kind of it all shakes out in the end?
So, Lindsay, let me take this because I'm passionate about this, right? And I'm going to tell all your listeners, look, if it looked like a duck and it quacks like a duck, you got to call it a duck. And what I mean by that is that if your protocols say that dizziness or balance, the eyes are part of the postcerebellar assessment, and you find that it's positive in the patient, you must call it. There's an acronym out there that, and there's many different acronyms out there that people use to try to identify stroke mimics. And they really try to rule out a stroke in the field. And this is where you're playing with fire, right? So I'm going to talk about an acronym that some people use, and not all, but some people use. And before I even mention this, it doesn't matter what you're thinking. If you have a positive result, you got to call it, right? So one of the acronyms that we use for stroke mimics is BEHIND, right? It could be a brain. The B is for brain, and there's a tumor, the contusion or Bell's palsy, right? That's what the B is. The E is for epilepsy, some electrical disturbance. The H is for high or even low blood sugar or blood pressure. The I is for intoxication or some type of infection, systemic infection. The N is neuro, so the migraines, the multiple sclerosis, and the D is for dissection or vessel dissection. It doesn't matter, right? So EMS clinicians, if they meet the criteria that you've been taught, you need to call it. And if you report to a facility and they act differently, you did the right thing, right? So they do their assessment and they think it's something different. It's okay. But you did the right thing. So your protocols tell you what to do. You need to follow them. If you see it, you call it.
Yeah, but okay, just to push back a bit. The question though is for hospital partners, right? Because I'll tell you what, it's very difficult to show up and be told, be basically told, oh, you're overplaying something. So how does that work? And how do we continue to advocate for our patients in the face of that, in that acute, few minute space where you believe something is to be a stroke and the immediate person may not believe it to be?
Kenny, I'll take this one. So, and then I'll let you go after. But so I get this question all the time. I get this from ER doctors. I get it from, nurses. I get it from PAs, NPs, from EMS providers. My response is patients can still have vertigo and have a stroke. Just because you have vertigo doesn't mean that you can't have a stroke. So, when we look at these patients and how do I, as a stroke coordinator and how I did it as an ER nurse, how do I differentiate or how do I try to determine the difference in a couple questions? Again, it's investigating. So we're going to ask, dizziness. I see a lot of triage notes. Patient reports acute onset of dizziness 1 hour ago. That doesn't really tell me anything. And when EMS providers tell me that over, the consult or in person, I ask a couple questions. Was it with acute onset? Does anything make it worse or better? Is the room spinning in a circle? Or do you feel lightheaded, like you're going to faint? So when I give patients that visual representation, we can be lightheaded, like we're going to faint from a lot of things. Low blood sugar, high blood sugar, dehydration, high sodium, low sodium, any electrolyte abnormalities. But room spinning dizziness is concerning. So even if somebody, comes to me and says, I have a history of vertigo, I take meclizine, and they're experiencing room spinning dizziness, and they're in the ER. My next question to them is, does this feel like your vertigo or does this feel different? Because 9.9 times out of 10, when this truly is a cerebellar stroke and they're projectile vomiting with it also, they're going to tell me it's more vigorous, or they're going to say it feels like there's an earthquake in my brain, or I'm standing and, or I'm sitting in a car and the car is driving forward, but I'm staying still. So, that's where your clinical judgment comes into play so that you can have those tools when, you walk in an ER and they're like, nope, it's not a stroke. It's, but ask them, just because this patient has vertigo, does that mean that they can't have a stroke also? The next question I wish we could ask is, how many cerebellar strokes have you missed? But we can't ask that. So just ask. So we can't ask the hospital that, but we can investigate more with patients and their chief complaint of dizziness.
So CNN just came out about almost 2 years, about 2 years ago, with the top 5 conditions that were misdiagnosed in the ER. Number 1 was stroke. And when stroke was missed, 17% of the time, people reported dizziness and vertigo. So EMS providers, don't be the miss.
You know, it's interesting the amount of times that we call and through the hospital stroke assessment, they get downgraded, though. I will say
And
that.
But that's where it doesn't line up either. And that's what puts both, the hospital and EMS at a disadvantage, because we don't have a congruency in the level of training. I mean, we can't expect you to adhere to and know our protocols the difference with me is that I do know your protocols, but I don't know every single jurisdiction's protocols. So, until we can, educate on the same level, we can't judge either of us, because neither the hospital and neither, is EMS. And sorry, Kenny, neither is MIMS. No one's, perfect. So
Yeah,
these strokes aren't missed, but like Kenny said, don't be the person that the hospital can blame it on.
yeah. And then on top of it, I think each hospital's response is different. Like the two that I can go to, one is a primary, one is not primary, one is just a regular stroke center, and one is a primary thrombectomy capable. Typically, at the thrombectomy capable one, at least during the day, the neurologist will come down to the ER if we call a stroke alert, and he will do an assessment. Nighttime, it's an ER doc. At the other one, it's always an ER doc. So it's definitely, oh my God, definitely a different reception. And then you're completely up to the subjective nature of their assessment. Whereas I believe when you go to the thrombectomy capable center and you have a neurologist, he's probably going to err on the side of let's check everything out. But definitely I've had ones that I've called and they just downgrade to a hallway bed or to a room, and we'll get a CT at some point. But it's kind of hit or miss. I don't know. At Moose, I know where he works, it might be a little bit different. It's a little bit more stretched out and resources wise and distance. So
Yeah, and I'll tell you guys what the one biggest tip that ended up helping me, and we'll talk about the case that I'm talking about, and what ended up helping my patient out was this. You got to know your job, and you got to know how to communicate effectively and advocate for your patient. If you do a consult and you forget to do a Lambs or a Cincinnati on a patient, the confidence that the hospital is going to have in you plummets, right? Similarly, if you show up and you say, "Oh, my patient," or if you show up and you haven't said anything about a stroke, and your patient has like severe facial droop and can't talk, the hospital team is going to lose confidence in you overall, right? So the biggest thing you got to do, in my opinion, is know your job, know your role, know your protocols, and know why the protocols exist, not just have an ancillary understanding. So that when you show up and say the first line person meeting you says, this isn't really a stroke, you can say, no, like per our protocol, this is a stroke, and you can then find another member of the hospital team to advocate to. My case was a patient. They were driving their vehicle and had a sudden onset of room spinning dizziness to the point where they had to like immediately stop their vehicle and pull over. Their child then picked them up and brought them to their home. And the first thing I did when I walked up to the patient was extremely nauseous. And again, the dizziness was just as bad. And the patient told me that the last time they had a stroke, the same thing happened. So in my head, I'm thinking, oh, this is clear cut, right? No other symptoms, no other deficit was clear, speaking to me clearly. Cincinnati was 0, Lambs was 0. But the patient had a lot of dizziness. So what I did, yes, at the ALS level, I did give Zofran. But everything else I did quickly, obviously check the sugar, blah, blah, blah. I even got the dude's neurologist, well, I guess I should say the patient's neurologist, information. And then we got him to the hospital. I stroke alerted it. And the initial folks that met me weren't really buying it. So I ended up finding the provider for the patient, and the provider was like, oh, no, absolutely, this is a stroke. And they went to the rest of the team and said, yeah, stroke alert this individual. And they did. And that's when we went directly to CT. So the thing is, though, if I didn't have a convincing story and I didn't know what to look for, that patient would have been just probably put in the hallway, to be completely honest with you. Right. I mean, if just because there was a lack of symptoms and that first level of triage discounted it as something else. So that's, when we talk about ownership and what we can do, we have to know our jobs. And then at the end of the day, we can only do so much. Certainly, if the provider also discounted me, then hey, I could be wrong too. I might be missing something. So in that case, I knew I didn't. But we're all human. But if you know your job, I feel like that's 90% of the battle.
100%, Moose. That also made me start thinking, and I want Kenny his advice, and then I also want to see what Moose and you and Josh think about this. Something that's been coming up, not just in Harford County, but kind of around the state. And Kenny, I'm sure you hear it all the time. Is I have a lot of EMS providers that say that they can't do a LAMS because the patient is either unresponsive, unable to follow commands, or essentially just under the unable to assess criteria. So how, there isn't a clear-cut way to determine if the patient is having a large vessel occlusion in an unresponsive patient, because we can't do that. But Kenny, can you speak to some things, helpful tips that we could give out as pearls to our EMS providers?
Yeah, I think history taking is really important, right? So if they're at the point when you arrive of just totally unresponsive, right? This is where our assessment skills and history taking becomes crucial. So trying to figure out what happened, how did they present, what happened when it started, and then if you see progression. So if you had the facial droop, and you had some arm weakness, you had some grip strength that wasn't too strong initially, and then when they went unresponsive, that's key for hospital personnel, right? So my advice is be a good investigator while you're on scene, right? Try to get that history. And most of the time that will lead you into where you need to go. Something that we haven't talked about that I think it's important to talk about is we talk about this fast and then this B fast and then this LAM score. And for your listeners across the globe, it is in our state, my office designates different levels of stroke centers. So it's important to understand that when we're assessing for LAM score, our protocols say if it's greater than 4 and the maximum for this score is 5, then we predict that it's a large vessel occlusion. That means it's something that we can treat more than just a thrombolytic. So I want to break down for your listeners really quick what it means for us to reroute people to different centers. So there's 4 levels of a stroke center in the state of Maryland, right? The first level is an acute stroke ready hospital. This hospital is designated to have the capabilities of administering a thrombolytic, so a clot busting medication. In the state of Maryland, we have 39 stroke centers. 38 give the drug tenecteplase, 1 give alteplase. So an acute stroke ready, it's capable of doing a stroke assessment 24/7, 365, and giving a thrombolytic. The difference between an acute stroke ready and a primary stroke center is that this center can do the same thing as an acute stroke ready, plus they can admit someone to an intensive care unit where they can monitor someone. They have neurologists on staff that can call in, that can check in with the patient. So this is where our LAM score comes in. When we have a LAM score 4 or greater, we predict that there's a large vessel, something that we can actually go after surgically. So a thrombectomy stroke center can do everything that an acute stroke ready hospital can do everything that a primary stroke center can do, and can also remove a clot manually. So it can go into the groin, into the wrist, going to the brain, and remove by either suction or using a stent retriever the clot from the brain. That is the capability of a thrombectomy stroke center. Now, the next level is a comprehensive stroke center. A comprehensive stroke center can do everything that a acute stroke ready could, everything that a primary stroke center could, everything that a thrombectomy stroke center could do, in addition to doing other surgical procedures like aneurysmal coiling, aneurysmal clipping, They could do decompressive hemicraniectomies when the brain is swelling. They can also manage carotid diseases, and they do the research to figure out what's next and then what's next. So a LAM score of 4 or greater reroutes us to hospitals because we have a sensitivity of 81% and a specificity of 89% at a minimum, and sometimes it's the low 90s, depends what research you read, that there is something that we can go after, and it's only a thrombectomy or comprehensive stroke center.
Oh, we should state though that in terms of EMS in Maryland, right, for our Maryland listeners, it doesn't matter if it's primary stroke with thrombectomy capability or comprehensive. Just take them to one of them, right? That's important to understand. In terms of our protocol, if it's a LAMS of 4 or greater, you take them to one of those, because a lot of times there's a little bit of confusion of what that means.
Yes, our protocol is if it's a LAM score of 4 or greater, you go, if you're within 30 minutes, you go into a thrombectomy capable or a comprehensive stroke center.
All right, so where do you guys want to go from here? We can talk about some long-term outcomes. There's a few other any topics you guys really are burning to talk about that we haven't talked about yet in terms of stroke.
Yes, I have one more thing I'd like to bring up just as an EMS pearl. So like Kenny said, with getting a detailed history, that's more than just writing down a list of meds. That's very important because we're looking for a couple things. And we're looking not just for blood thinners, but we're also looking at what other disease processes does this patient have to increase their risk. When we look at patients that you go to, their house or a skilled nursing facility or rehab that for acute onset of stroke symptoms, the most important thing to ask them if they've had a history of a stroke, again, is what deficits were you left with, residual deficits? Because that's very important because we want to know from the hospital, is this new or is this old? But you also can have acute onset of worsening deficits in, if you have residual right-sided weakness, and if you have an acute onset of worsening right-sided weakness, we still treat that as a new stroke and as new symptoms, even though that one side is residual. We want to make sure that there's no bleeding, no hemorrhagic conversion, the old dead tissue that can turn to blood. We want to make sure that that's not too large of an area, but you can, a vessel can be occluded in the same area, not by the same clot, hopefully, but it can be, the same vessel can be occluded twice.
And on this topic of the unconscious patient and getting that history, not to go super basic on this, but hypertension. If you've got a patient that is unconscious with a reported history of a stroke and they've got hypertension, err on the side that it is a neuro event of some sort. I don't care if you want to err on the side that it is a head trauma and you go to a trauma center, or you want to err on the side of a being a stroke. You're throwing those dice, and 9 times out of 10, I'd say that's a rough number. Obviously, it's going to come up neuro event. Hypertension crises, can they result in unconsciousness? Sure, they can. Can we have other issues going on that result in unconsciousness from hypertension? Yes, but most of the time it's going to be a neuro event, stroke, or a bleed of something in the brain. Okay, causing that pressure to jack up, causing the CPP, ICP, everything to go up, all tied together. So just err on that side. And as Kenny said before, don't be the one who creates the miss. It's simple. Just get that vital, correlate it all together. Everything ties together. This is not just in neuro events. You need to tie all your pieces of the puzzle together. That's part of this whole job. Being that detective, figuring out why this presentation doesn't match this part, or maybe they do match. I had one that popped up in the inbox the other day from someone that they treated as CHF, and it probably was CHF, but it was also probably 2 other things of AFib with RVR and hypovolemic shock. And the blood pressure that was reported, taken by a life pack, did not fit the skin presentation or the possibility of CHF. So what's going on? Figure it out. Same thing. If you have the hypertension and you think it's neuro, piece it together. Just go to the right center. Don't be the miss.
Unresponsiveness, syncope, dizziness, they're all neurologic symptoms. And that's what, when we look at teaching nurses, what classifies a neurologic symptom? Unresponsiveness, acute change in mental status, altered mental status. Those are all also neurologic symptoms of stroke. So again, we can't rule it out. If there's obvious signs of trauma, you're gonna, better safe than sorry, go to a trauma center.
Kenny, do you have anything else?
No, I loved you, Josh, you bringing up the hypertension. It's always something that we discuss, and it's weird because it's the number one cause of strokes, right? And then when you do have a stroke, your body's response to fix itself is to try to push blood through collateral circulation, and by doing so, it increases your blood pressure, right? So it's the body's way of helping itself, and our protocols at least say just leave it alone, let the body help itself, identify it, it's going to go up, and it's get them to the place as soon as you can.
Awesome. Well, this was a awesome discussion, I think, on stroke. Even though we had to do it twice, I think it was pretty good. So closing comments from Lindsay, then Kenny?
I just want to say thank you, Moose and Josh and Ken, for having us on here. I appreciate the opportunity, not just as the EMS subcommittee chair for stroke, but as a fellow EMS provider. I mean, we really need to bridge this gap with education, not just for stroke, for everything. We can't expect you to be nurses and doctors, but we are doctors on an ambulance. We don't have imaging. We don't have blood work. We don't have respiratory. We don't have an OR. We don't have a neurologist yet until we get the mobile stroke units, Kenny. But you guys truly can make a difference in these patients' lives. Like I said, they're not, the hemodynamically unstable trauma patient, but these patients historically were not walking out of the hospital with large strokes. Now we actually have, multiple treatments, but 2 huge treatments that can help, these patients not be paralyzed. For reference, side note, 7 years ago, my stepdad, he was 55. He was a Baltimore City fireman. He was a pump operator. He, went into burning buildings for a living. He drove a fire engine with his right foot. He did suffer a very large ischemic stroke, had to medically retire at 55 because his entire right side had hemiparesis. He still, can drive now, but it was rough for a little bit. But, just think about that. Anybody can have a stroke. It's not just an old person's disease anymore. So, truly think about it, and you really can make a difference. And I thank you guys again. Let me know if you need anything. I'm here.
Yeah. I also want to say that thank you so much for having me on here. This disease, like Lindsay said, does not discriminate. And the frequency of this disease, every 40 seconds, someone in the U.S. has a stroke. Every 3.5 minutes, someone dies of a stroke. It affects approximately 800,000 people in the United States. This also is the number one cause of disability. And it's the 5th or 4th, depends what you read, leading cause of death. This is huge. And one thing that we can do is make a difference. We can make a difference in our assessment skills, being timely, and sending patients to the right location. Every single person that you encounter is so important. Remember that family members, they pray for you as an EMS clinician to do your best for the loved one they have. Your talents are someone's gift. Each person is real with true feelings and needs, and each person is loved by someone so much, and you may never, ever get to meet them. So do your best. Thank you so much for having me, and I appreciate the conversation.
Yeah, we really appreciate you guys having, you guys taking the time to come on. Certainly we wouldn't be able to do what we do without having experts in the field come on and have conversations with us. So we really appreciate it. Josh, you want to close us out?
Yeah, sure. So, Lindsay, Kenny, thank you for coming on today again, as no one else will ever hear the other one, but again. Whoever else is out there listening, make sure you're following us on Instagram, wherever you are. Good morning, good evening, good night, good afternoon, whatever it is. And be safe. And we're out. See you.